Hello, everyone. Thank you for joining us at the Care Answered webinar. We are doing this webinar in recognition of Mental Health Awareness Month, which affects everyone. So for those who don't know me, my name is Nicole Christensen. I'm the CEO and founder of Care Answered. I'm a board certified patient advocate and the author of the book From Crisis to Calm. And to tell you a little bit about Care Answered is we navigate people through the healthcare system. Our mission is to access the best care for our clients while giving loved ones peace of mind and empowering all patients. And that is a real part of this webinars series so that we can get and distill information out to all people, all patients, so that we can access our own best care. So I'm very excited to have Jamie Rosen with us today to help us to understand better how to navigate a mental health crisis. So I'm going to start off with a few statistics that I found interesting that may help us to kind of put things into perspective from our personal lives, our professional lives. I know working with clients, although I didn't necessarily know these statistics before, I certainly have seen it played out. So one is that 14% of adults over 50 experienced mental health illness, and 3% age 50 and over experience serious mental illness. So when we say that age of 50 and over, where in my world of advocacy, especially for older adults and their families, we're really talking about, in my case, the caregivers. And then I'm going to give you some statistics about potentially the client, the older adults. So fewer than 40% of older adults with mental or substance abuse disorders receive treatment. Between 25 and 30% of older adults report anxiety and depression disorders. So that's the reporting. And depression is the most prevalent. And it can lead, that many of us have seen, right? It can lead to impaired physical, mental, and social functionality, and often adversely affects the course and complicates the treatment of other disorders. So it's playing out in all of the lives of the citizens of the United States and, of course, across the world, but those are stats for the US. So without further ado, let me introduce Jamie so she can talk to us more about how to navigate these crises, because we've worked together, as many of you know who have seen these webinars before. This is part of the Care Answered family, people that we know and trust and work with that help our clients immensely and have great information to share. So a little bit about Jamie, besides being part of the Care Answered family. Jamie Rosen is a partner and chair of the mental health law group at Meister Seelig Fein PLLC, dedicated to representing individuals and families in all matters related to mental health issues and/or alcohol or substance abuse disorders. Her knowledge of the mental hygiene law includes inpatient hospitalization, outpatient treatment, discharge planning, adult guardianship proceedings, mental hygiene warrant proceedings, and family court order of protection matters. Recognizing that these complicated mental health issues require a team approach, she collaborates with many healthcare and mental health professionals to develop the best clinical plan and legal course of action. And I have had the wonderful opportunity of working with Jamie in the past, and really her knowledge is more than any I've ever met, and it's so appreciated. So thank you, Jamie, and I'll leave you to it.
Thank you so much, Nicole. It's good to see everyone today. I see a few familiar faces, and so I thank you for joining me. To the new faces out there, it's very nice to meet you. Today, we are discussing how to navigate different mental health issues that may impact older adults, and how I really work with clients and their family members who are living with and dealing with mental health issues. So Nicole, can you just confirm that you can see my screen?
Yes, we can all see it.
Okay, good. All right. So I'll highlight a few areas and issues today: hospitalization for serious mental illness, estate planning surrounding mental health issues, and capacity and guardianship issues. First, it's really important to understand what we're talking about. When we say mental health, when we say mental illness, terms like cognitive impairment or decline, and talking about older adults, there are several different types of neurological, psychiatric, medical conditions that can really impact cognition, functioning, and cause symptoms. When we talk about dementia or Alzheimer's, many of us are familiar with the stereotypical symptoms of dementia: decline in memory, executive functioning. But with dementia, we can also see depression as people struggle with the loss of their independence, the fear of the future, and we can see paranoia. With depression and other mood disorders in older adults, such as anxiety disorders, these symptoms could be occurring because of an increase of different medical issues, a loss of family and friends. We might see a change in sleep or eating patterns, low self-worth, delusional thinking, low energy, isolation or withdrawal from social activities, and a decline in personal hygiene. Then we have chronic mental illness. You'll hear diagnoses such as schizophrenia or bipolar disorder, for example. And these are conditions that present really lifelong impairment of judgment and mood changes that can worsen with age. When we talk about mental health concerns, we should be looking for red flags, whether we are mental health professionals, medical professionals, attorneys, or just laypersons looking out for our family members. And so what are some of the signs that someone might be in distress or changes that you might see that I call a red flag? And really, when you put all these pieces together, you start to see the bigger picture, and that might heighten your concern about the person's overall well-being. So for example, an inability to manage daily activities such as showering, toileting, personal hygiene, eating, dressing, cooking, or shopping. In our senior population, signs of an inability to live safely in the home might be leaving the water running and forgetting about it, leaving the stove on and forgetting about it, rotten food in the refrigerator, any decline in personal hygiene. Other concerns should be a refusal to see a doctor when it's necessary, refusal to take medications when they're prescribed, hoarding behaviors in the house, disruptive behaviors in the community, maybe if they live in an apartment building, yelling or other inappropriate actions toward their neighbors, isolation or withdrawal from activities, delinquent bills or mail piling up. So what are things that you can do when you have concerns about someone's mental health? Some things that people don't even think about, as simple as speaking to the individual about your concerns. If you have consent, in terms of escalating your concerns, if you have consent, maybe speaking to the individual's primary care physician. When was the last time they went to the doctor? Did the doctor have any concerns or recommendations? Bringing the individual to their primary care physician for an exam. If appropriate, after that exam, asking for referrals for mental health professionals, if it's appropriate. If a concern rises to the level where the individual will not comply in seeing a doctor, getting an evaluation, If the symptoms are really rising to a level where now you're worried about safety, there's a risk of harm to either the person or others, you may have to get the individual to a hospital. Then the question becomes, how do you get them to a hospital? There's always the voluntary route. The person has enough insight or understanding that some change has happened, something's wrong, something needs to be evaluated, and they voluntarily will go to a hospital. The other options really are involuntary. So if there's some type of emergency, an incident that happens and 911 is called, you're really looking for a 911 call, in this case, to lead to an emergency room visit. You're not looking for an arrest or other intervention. It could be just a wellness check. Someone comes to the house, usually with a police presence, to see what's going on and evaluate whether or not the individual needs to be taken to a hospital. There are mobile crisis teams in all counties throughout New York that do these type of assessments in the community. So for example, sometimes they'll do an assessment over the phone. Sometimes they'll do an assessment in person. And it's essentially a mental health provider, either a caseworker or social worker, that comes out into the community to do some type of assessment to determine what's going on, whether or not this person will accept services in the community if it's appropriate or needs to be taken to a hospital. There's a legal proceeding called a mental hygiene warrant. I'm not going to get into the complicated process of a mental hygiene warrant, but essentially it's a legal proceeding where now you're asking a court. You're asking a court to become involved, either with an attorney or without. You're filing papers in a court, asking the judge through sworn testimony to send the individual that you're concerned about to the nearest emergency room for an evaluation. It's important to understand that the court does not have the authority to order an involuntary admission of the individual to a hospital for psychiatric treatment. All we're getting through this proceeding, through this court proceeding, is entrance into the emergency room. Then it's really up to the hospital and the protocols within the hospital to determine whether or not the individual meets the criteria for an admission to the psychiatric unit. What I want to say about the route of calling 911, because often I get a call that 911 was already called and their loved one is on the way to an emergency room at X, Y, and Z hospital. It's really important to know what to do if you're calling 911, and not to rely on the police and whoever is responding to the scene to be really trained in mental health evaluations and how to respond appropriately. So I work with families on what to do and how to provide information and how to ensure everyone's safety the best that we can. So when you're calling police and you're providing the reason for calling and then following up afterwards, I'll tell family that if it's at all possible to be present at the scene when the police are called, to be able to speak to the police officers and provide background information and the context for the 911 call. Often the individual who's in distress or denying needing assistance is not going to be a reliable reporter to the police about their condition and what's going on. Same thing with the mobile crisis team. If you're calling for a mobile crisis team and a mobile crisis intervention at your home or the home of a loved one, it really does make a difference to be able to present information and background and the context for why you're asking for help and the history, and maybe there's an already existing diagnosis, really explaining the symptoms that are concerning. Because when these teams or when the police show up to an individual's house, often what we find is the individual may have been through the system already. They know how to pull it together, they're manipulative, maybe they know how to pull it together enough to hold a conversation with the police officer or with the social worker that's evaluating them. And then the police leave and it empowers them. See, there's nothing wrong with me. They didn't take me to the hospital. They didn't do anything. They just left. So it's really important for the support being able to convey the message to the team or to the police on the full history and context of what's going on in the house. So what happens once a person is taken to a hospital? So the person will be evaluated in the emergency room. A clinician has to determine whether or not an individual meets the criteria to be admitted for psychiatric treatment. Generally, they'll be cleared medically first and then evaluated by a psychiatrist or other clinician to determine, does this person suffer from a mental illness? Does this person pose a substantial risk of harm to themselves or others, such that they should be admitted for psychiatric treatment? Another place where advocacy comes into play is in the emergency room. So just like you're facing issues of getting the person to a hospital and feeding information to police or a mobile crisis team, we have to feed information to the emergency room and to the staff and the admissions staff on what's going on, what happened at home, why does this person need a psychiatric evaluation? What's the diagnosis if they have one? What are the symptoms? What's the history? When was the last time they were hospitalized? Are they seeing their psychiatrist? Are they disconnected from care? If the family that I'm working with can't go to the hospital in person, we advocate by phone. And the key is really providing that collateral and background information. In terms of the benefits of hospitalization, the hope is that it allows for treatment of any acute symptoms and the resolution of any dangerous or disruptive behaviors that were occurring at home. The goal is ultimately for the individual to return home at an improved level of functioning, compliant with appropriate medications and continued treatment and outpatient treatment, and staying connected to care upon the discharge from the hospital. However, there are many issues to manage while a person is in a hospital for psychiatric treatment. One of the biggest issues to manage is access to information and records while the person's on a psych unit. The patient can refuse, basically say to their treatment team, to their doctors and social workers, don't speak to my family, don't share information. And that puts up a real wall for families in terms of being able to
No, I don't want to feel.
understand what treatment is occurring, what is the discharge plan. I always tell families, you can still provide information. You can advocate from the outside. You can even advocate from the inside, meaning go visit your loved one, go visit your friend or family member. There are real benefits to talking in person, just showing up for visiting hours, seeing them, seeing hospital staff face to face. People like to talk. It's much easier to refuse to pick up the phone or fail to pick up the phone. When a family member calls, it's really hard to ignore someone when they're there in person on the unit, asking to speak to a social worker, case manager, or the treatment team. One of the major issues with hospitalizations is that hospitals don't keep patients for very long. If the person is on their best behavior, they'll be discharged quickly. If they're taking their medication, they're going to group activities, they're behaving appropriately, they're taking care of their hygiene on the unit. All of these things add up and lead to a quicker discharge. If a person starts to act out on the unit, isn't cooperating, isn't taking medication, those behaviors can prolong a stay in the hospital. Then the hospital starts to consider interventions such as emergency medication if it's appropriate, treatment over objection and going to court for medication for the patient, and the length of the stay increases. Still, acute care hospitals are really meant to be short stays. The real work comes with the discharge planning and ensuring continuity of care in the community. We don't want a discharge plan to be simply, here's your medication, here's a prescription, here's a follow-up appointment, a few days worth of pills, and best wishes. We really want a full, comprehensive plan with accountability. If the person meets criteria, we want to be advocating for an ACT team or assisted outpatient treatment services, which is services that are court ordered. We want more than just an appointment. We want supervision in the community if we can get it to ensure compliance with treatment. a lot of times discharge plan meetings or family meetings that we request, there might be an outpatient provider that was previously providing services to this individual who can be a valuable resource and involved in discharge planning. Now, this first part of the presentation was really about an acute mental health crisis, going into a hospital, managing a discharge from a hospital. I want to switch gears a bit and talk about the steps you can take when an individual is not in an acute crisis, so that you can plan for their future and for yours. The documents we're going to talk about, they're really important on both sides. What I mean when I say that is that the mentally ill, the elderly individual should really have their estate planning documents in place, planning for their eventual incapacity or their death. But also the well members of the family should have their estate plan in place. For example, you don't want to leave assets to a disabled, mentally ill family member that would jeopardize or disrupt the receipt of benefits. And if you're a mental health professional, a financial advisor, or an attorney, these are all tools to explore with your clients and maybe recommend that your clients speak to an attorney about these tools. So in talking about advanced directives and estate planning, the threshold question is really about capacity to sign the documents. That's where an attorney comes in to assess whether a client really has capacity to, and then advising on how to best proceed. So does the person understand the document, the consequences of signing the document? Basic questions like, is he or she oriented to person, place, and time? There are so many questions to ask to determine if the person really understands and appreciates the benefits and the risks and the effects of signing. I wanted to highlight here that simply having a diagnosis, whether it's early onset dementia or mental illness, bipolar disorder, simply having a diagnosis does not automatically mean that the individual lacks capacity to sign these estate planning documents. I'm going to go over a few of these documents briefly. So what are these documents? Why are they important? And I want to briefly highlight these documents before we talk about what happens if you do not have these documents signed before you lose capacity. So a healthcare proxy. Many of you may be familiar with this if you're in the healthcare industry, but this is essentially a legal document where a person can designate an agent to make medical decisions for them in the event of their incapacity. This includes decision-making to remove or provide life-sustaining treatment. It also allows access to medical information or medical records. But it's important to note that in talking about mental health issues and psychiatric treatment, an agent under a healthcare proxy cannot consent to psychiatric medication and cannot consent to the involuntary admission to a hospital for psychiatric treatment. So there are limitations with this document. Even if you have it, it doesn't cover everything. The living will is really the opposite of what it sounds like. It's a document that essentially states your end-of-life wishes, that you don't want extraordinary measures, maybe just comfort care. Power of attorney is a legal document where you're designating an agent to manage your finances. So access your bank accounts, pay your bills, pay your taxes, manage your real property during your lifetime, whether you have capacity or not. This document can be used. It's not necessarily dependent upon your capacity. Then we have a last will and testament, or a will. This is a legal document where you designate an executor of your estate. So once you die, who's going to be responsible for collecting your assets and your property and distributing them in the way that you have designed upon your death? Who will serve as the guardian of your children if you have minor children when you pass away? Really, without a will, you're relying on the default provisions of New York law to dispose of your assets when you die, to designate who will be the administrator of your estate, who will collect your assets, and how they will be distributed. Lastly, we have trusts. These are legal documents that can be created to provide for minor children, to safeguard estate assets from creditors, or estate taxes, and to prevent interference with a beneficiary's government benefits. That really brings us to, what happens if an individual refuses to sign a healthcare proxy or a power of attorney? What happens if the person has signed these documents, but maybe they were not signed properly, or they don't cover every scenario and situation that may arise? What happens if the person really cannot manage their own affairs, has no insight or understanding into their illness, into their limited ability to to look out for their own best interests? What happens if the person lacks capacity? That's when we start to talk about guardianship. Now, recently, guardianship has really been splashed across every, front page tabloid and newspaper because of the major celebrity cases. We saw a lot of news coverage with Britney Spears and her conservatorship in California. And guardians in the guardianship courts are not portrayed in the best light, I'll say. Really, in my practice, I carefully evaluate all the options with the family, less restrictive alternatives before we go into court requesting the appointment of a guardian. And I found, and I know many other attorneys have found guardianship to be a very effective tool when used properly, as a long-term solution to help someone manage their personal and financial affairs in the event they're unable to manage their affairs themselves. So what is a guardian? A court can appoint and oversee a legal decision maker or a guardian for another adult who, due to incapacity or other disability, is unable to manage their own affairs. So in New York, they divide up a guardianship into two areas: personal needs guardian and property management guardian. In New York, for a court to determine that an individual requires the appointment of a guardian, you really have to demonstrate the person suffers from functional limitations. These are limitations that impair the person's ability to provide for their personal needs and their property management. The person really lacks the understanding and appreciation of the nature and consequences of those limitations, and the person will suffer harm without the appointment of a guardian. When we say functional limitations, really, what does that mean? So this goes back to when we spoke about earlier, activities of daily living. So maybe an inability to manage those activities of daily living: mobility, eating, toileting, dressing, grooming, housekeeping, cooking, shopping. And then money management issues. So banking, paying bills, any activities related to money management. Functional limitations might also be safety concerns at home. So like we said, leaving the stove on, signs of dehydration or malnutrition, trouble navigating the stairs, driving erratically, getting tickets, not paying them, acting inappropriately toward your neighbors. I've seen many cases with hoarding issues in the home, and that becomes a safety issue. Functional limitations may also be refusal to see a medical or mental health professional, refusal to accept assistance in the home from a nurse, a home health aide, or other service that's necessary to ensure safety. When we talk about functional limitations in terms of property management, it can surface in many ways. So we've seen frivolously spending money or giving money away. That can lead to issues with elder abuse, people getting taken advantage of when they are experiencing impaired judgment and being taken advantage of. Refusal to apply for eligible benefits. So maybe the person's eligible for Social Security or Medicaid or food stamps or any other type of benefit, but they refuse to cooperate, refuse to apply. Maybe they were already receiving those benefits, now they're refusing to recertify them and they're at risk of losing the benefit. This comes hand in hand with maybe not opening their mail, not paying their bills, not being able to manage their income and their assets, not being able to maintain their home. So I've seen cases where an individual is at risk of eviction, really at all stages of an eviction. So where there might just be a threat of losing the home, where an eviction is actually pending. So In those cases, it might be that the individual is in complete denial, refusing to cooperate with legal counsel, refusing to cooperate with the court system, completely in denial, and will not acknowledge that there is a pending eviction against them. The question then becomes, now we have this whole laundry list of limitations, of issues that are presenting in the home. What can a guardian actually do? In terms of personal needs, the guardian can be granted the authority to access medical and mental health records. This means that the guardian can overcome HIPAA limitations so that when a person is hospitalized or when a person is seeing a doctor, the guardian can speak to the providers, can view the medical records, and there's no issue where the hospital or the doctor can say, we don't have consent to speak with you. Now the guardian can override that. The guardian can also make appointments, assist with getting to those appointments, encouraging compliance, everything the guardian can do to get the person to the doctor, short of, putting them in a car and driving themselves. The guardian can also be a huge part of coordinating a discharge plan from a hospital. The guardian can access the individual's residence, including authority to maintain key access. So sometimes we have someone who's really isolated and withdrawn at home and will not let anybody into the apartment. I've had cases where they won't let the superintendent into the apartment to do maintenance or repairs or, you name it, they won't let anybody in. So now you have a guardian who can go in and have access. The guardian can hire a cleaning service if that's an issue, hire a plumber, repairman, whatever needs to be done to keep the person in their home and keep them safe. Along those lines, a guardian can hire all types of support services. So a companion, a home health aide, a visiting nurse service, or a case manager. And in certain cases where you can really establish that it's not safe or appropriate for the person to be living independently in their home, a guardian can apply to the court to choose place of abode, we call it, to relocate the person to an appropriate or higher level of care, and that's subject to court approval. In terms of property management, what can a guardian do? The guardian will set up what's called a guardianship bank account, a checking account, and marshal the individual's income and assets. So now the guardian has control over the money and is collecting the income every month, if there is any, and is paying the bills and keeps very good, clear records of money coming in and money going out, and has to report to the court every year about that money management. So the guardian opens a guardianship bank account, pays the bills, files and pays taxes if it's necessary, creates a budget, and maybe gives the person spending money, and monitors the spending. The guardian can access confidential financial records. So along the lines of HIPAA and not being able to access medical records, the guardian can also now access financial records. Guardian can apply for recertify benefits, and the guardian can defend civil proceedings such as an eviction. That may include hiring counsel, appearing in housing court, whatever needs to be done to secure the person's housing. What I want to highlight in talking about psychiatry and mental health issues when you're talking about a guardianship for someone who suffers from a mental health issue is really what a guardian can't do, because there are limitations on what a guardian can do. And a big part of analyzing with a client about whether or not guardianship is the best option is really what is the client's goals and can a guardianship achieve those goals? Like I said, a guardian can play a really crucial role in ensuring compliance with medical or psychiatric treatment, but there are real limitations of the statute. So a guardian can identify the appropriate mental health and medical professionals available, can make the appointments, can arrange for the transportation, can encourage the individual to attend, can even go so far as to accompany the individual to the appointment. The guardian can ensure health insurance coverage and apply for Medicaid or Medicare if it's appropriate. But a guardian cannot consent to the administration of psychiatric medication over the individual's objection. So if that individual is supposed to be seeing a psychiatrist and is supposed to be getting an injection once a month, but refuses to go to the appointment or refuses to get the injection, a guardian can't consent to the administration of that medication over the person's objection, whether in the hospital or in the community. Guardian also can't really force the individual to see a psychiatrist at all or attend treatment programs, can't admit the person to a long-term residential program if it's necessary. So there are real limitations. That being said, I have seen guardianships work wonders for individuals of all ages, really, who suffer from a mental illness. It provides much needed support for that individual to live in the community, stay safe, stay compliant with medication. It's a long process. It can be a very adversarial process, but it can really work for families and for individuals who need that type of supervision and assistance with both their personal needs and their financial affairs. The last few things I want to say is really, first, thank you for attending the program today, learning about these really important issues. Caring for a loved one with any type of illness, disability, mental illness is really stressful. It's really time consuming. The mental health system is really complicated and somewhat broken. I really help navigate clients through the dark. People ask, when should I call an attorney? It didn't even occur to me to call an attorney when managing a mental health crisis. I tell people there's really no wrong time to call for help. Sometimes I work with families during the calm in the storm and we plan ahead. More often than not, I get a call when a mental health crisis is well underway and we start to strategize and advocate immediately. But generally, you should reach out for help when you start to see those red flags and have those concerns. Any psychiatric symptoms, even if they're not rising to the level of a threat or not posing a risk of harm to anyone yet. So like I said, there's really no wrong time to call for help. When people call me, I'm pretty honest with whether or not I think I can make a difference, if I think I can be a part of their team. And like Nicole said, I really see this work as a team approach. I work with mental health professionals, patient advocates, case managers, social workers, agencies, nonprofits, financial advisors, any trusted advisor of the family, real estate professionals if we're dealing with housing issues, estate planning attorneys if we're dealing with those issues. I mean, really anyone can be a valuable member of this team. And I recognize that to make a difference in these people's lives, it really does take a team approach. And I can't wear all the hats. So if somebody calls me and I think that there's a different resource they need, I like to be able to say, I don't think you need an attorney here, you need Nicole, and be able to direct them to someone that's more appropriate for their need. And so I welcome any of you who work in this field or touch upon any of these issues, to reach out to me, because I'm always looking for resources for my clients to be able to help them in ways that I can't, and be able to direct them to services and resources that exist that I may know about, or maybe you're going to introduce me to services I don't know about. So thank you again, and thanks so much, Nicole.
Absolutely, Jamie. Thank you so much for that. One of the things, there's a few questions in there. Can everybody hear me, first of all? Okay. Can you hear me, Jamie?
Yep.
Okay. Some of the things that came up for me when you were speaking is one of the takeaways that I also tell all of my clients and anybody who will listen about is really starting early, whether it's mental health or not. But so often, Jamie and I have discussed this before, a lot of times with mental health diagnoses, it's kind of not talked about. And those who are fortunate enough to have wealth may have kind of hidden it without getting services so much, or maybe hiding those services, but have not planned on what happens when I'm not here, or I don't have the capacity for my child who is now grown. So it's really important to have these conversations, and that's why there's a Mental Health Awareness Month, right? To be able, so that these conversations are ongoing and ready, and there's nothing to be, there's no stigma in it. Where, as I read the percentages in the beginning, it's affecting all of us, all people. So, but the other thing that I wanted to mention when Jamie, you were talking about guardianship, is when you act early and you can get the power of attorney and healthcare proxy, right, should start at 18, right? You should have a healthcare proxy at 18. So those things should be happening early in our lives, no matter if we have a diagnosis of any kind. So somebody can make our healthcare decisions for us if we are incapacitated. And those are really important conversations that Kara answered. We do facilitate those conversations. We've worked with the young people going off to college, making sure all of that information is up to date, as well as people that are older that, you know, they say it's in their lawyer's office, or, you know, they made it 20 years ago and nobody's seen it, including the healthcare proxy themselves. So these are really important conversations. It's also, if we're just putting, you know, dollars and cents, it's much better to have those conversations earlier, get the healthcare proxy and power of attorney done, rather than going through the process of guardianship, right? That's a longer process and a more expensive process. So those conversations are truly important. The other side that you actually mentioned as well, Jamie, was when people have a diagnosis already, maybe they have a mental health diagnosis, and then additionally, they're getting older and potentially they have another diagnosis of dementia. So again, like in the statistics that I mentioned in the beginning, having a mental illness can, especially depression or bipolar, can definitely affect your so many parts of your life, but also chronic conditions that you have as well. So managing those are really, really difficult. So getting on board with it, knowing what your diagnoses are, not being afraid or concerned about getting the help that you need, and encouraging those that you love, or your relationship with, or just neighbors and friends, that there is help out there, just could make it a lot easier in the long run. So that being said, well, let's get to some questions I saw here in the chat. Where did they go? Hold on. Okay. Let's start from the beginning. Ms. Katz said, do you find patients sit in the ER for many hours or days? My easy answer is yes. Jamie, what's your?
Yes, I mean, it's really dependent on county to county, but if you're going into the emergency room, I mean, the most calls we get are, you know, Friday at 5 o'clock, and there's family members headed to an emergency room and could sit there all weekend. It really depends on what the staff looks like when you get to the emergency room, whether there are beds available, whether there's a psychiatrist in the building who's available to do an evaluation. It depends on the hospital. Generally, if you're taken to a hospital that has a CPEP, a comprehensive psychiatric emergency program, the hope is that they're more equipped, they're better equipped to do an evaluation in a timely manner, make a determination whether you require an admission or not, and move you either onto the unit or discharge you and not admit you at all. But certainly emergency room visits, you know, can be prolonged, and you can sit there waiting for a bed if they determine you're, you know, appropriate for admission. And then, for example, in Suffolk County, if you go to Stony Brook, and they evaluate you, determine that you need admission, then it could be that they're looking for a bed for you on a psychiatric unit all over Suffolk County, and you could end up at a different hospital on the psychiatric unit at a different hospital.
Absolutely. It is very, very unfortunate. And that is true for mental health or not, staying in an emergency room for days, but definitely with, if you're in there for a mental health situation. Also, the reality is, because I'm very transparent, right? The reality is that the amount of psychiatric floors or hospitals that really have knowledge about folks that are also older adults is minimal. So just trying to get the right care there. And one of the things, I think Jamie and I, we've discussed this in the past, but one of the things Care Answered works with is kind of a to-go kit. So if it's mental illness or physical illness, chronic illness, if there's a potential that you might need emergency room, having that information in lieu of being there like a loved one, like you said, if somebody can't be there, or even if they are, it's just helpful because everybody's kind of in a frenzy when somebody we love needs to be hospitalized. To have the information, the quick information about that person, like the diagnoses, like the medications, like their community clinician, their insurance, their healthcare proxy, all of that information there. So, and it's readily available. So God forbid something, they do need an emergency room, there, that information is there.
Yes, that's part of what I will advise families is to have, you know, you want it to be comprehensive, but you don't want it to be pages long. You want some
Right.
type of written document where you're putting together the highlights, the diagnosis, prior hospitalizations, really concerning symptoms, what just happened at home that led to your loved one going to the emergency room, and be ready to present it to the hospital, so that you have everything in a clear and concise way already written out. So when you get to the emergency room or when you get on the phone call with somebody, when you're in crisis mode, you're not always thinking straight. So you want to have something written, that they can read and understand about why your family member, whoever it may be, is in the hospital.
Absolutely. The other we have, how does it affect the individual and loved ones? It can be very hard, but I think what Jamie mentioned is the more prepared you are, the easier it will be, as well as the better care one can receive, because you are being your loved one's advocate in that case and scenario. But it is very hard, there's no question. A lawyer or advocate who specializes in advanced directives should explain in detail what it means to decide about extraordinary measures. Absolutely. Feeding tubes, intubated. Absolutely. Absolutely. We do that at Care Answered, and we work with lawyers as well, because sometimes the medical stuff is a little bit hard to really digest, right? About what you want your directives to be and what you want. So we facilitate in those conversations as well with lawyers sometimes, and sometimes lawyers
You
do
know,
it
lawyers
themselves.
have that conversation with their client when they're executing the documents, you know, that you're authorizing somebody to make these decisions on your behalf. And these are the decisions that they can make. And, you know, these are your options, and this is the direction that you're giving to your agent. But the piece that's often missing is the conversation with the agent, with the family member who ultimately has to make those decisions. And we rely on, you rely on the person who's signing the documents to have that conversation with their family member to say, hey, I'm appointing you as my healthcare agent. These are my wishes. This is what I want, and have that conversation with them. Most of the time, though, however, you sign a healthcare proxy, a power of attorney. Maybe you give a copy of that document to your agent to give them the heads up. Hey, you're my agent. You're my healthcare proxy. These are my wishes. But more often than not, the person is really caught off guard. And when they have to make the decisions and actually use the document, it's really challenging, especially for a power of attorney. It's a very long document. It's a confusing document. It's not very user-friendly. So I have a case right now where a client retained us to really help them understand and explain their role and responsibility as an agent under a power of attorney, now that they have to use the document to manage their mother's affairs as she's aging and unable to pay her own bills. And what can a power of attorney do and what can a power of attorney not do? Because like I said, it's really complicated. And you want to make sure that you're using the document correctly. You're a fiduciary and you have responsibilities. As a fiduciary, you want to make sure you're doing the right thing by your family member, but also under the law.
Yes, absolutely. I always call it there's often healthcare proxy by surprise or power of attorney by surprise, because there's not information, especially on the healthcare proxy, that has the person who you've selected actually sign. So oftentimes, as I mentioned before, it's in a lawyer's office, and that agent or that healthcare proxy doesn't really have any idea. They haven't had those conversations, and they just found out that they're in charge. And really, what it's supposed to be is I am just, if I am a healthcare proxy, which Precurrency doesn't do, but if a person is a healthcare proxy, then they are just voicing that person's wishes. They're there to vocalize it. So without the conversation, you can't be a good healthcare proxy because you don't know what you're vocalizing. It's not supposed to be that person's decision. It's supposed to be the healthcare proxy's decision. It's supposed to be vocalizing the decision of the patient. So again, we work a lot on that at Care Answered because it's so very important. And we've seen the other side of it. And it's very, very sad, and it's devastating to people to make those decisions without actually knowing what that person wanted. Somebody asked the difference between a healthcare proxy and a medical power of attorney. I can answer that, but I'll have Jamie do it. Is there a difference?
In different states, they use different language. As far as I'm concerned, in New York, we call it a healthcare proxy. But it's essentially any document that allows for making medical decisions as an agent under the document. There's another question about a psychiatric directive. That's a different document.
Yes.
Some
Yes.
states recognize psychiatric advance directives, others do not. That would be really a document that's specific to psychiatric treatment and isn't comprehensive in terms of managing all medical decision making. It's specific to psychiatric, and there's still real limitations to that document, even in the states that allow for it.
I did have one client that had that. Then Roseanne asks, why is the word hygiene used instead of health?
They're really interchangeable. When the law was passed, it was called the Mental Hygiene Law. There's a whole agency, New York State agency, Mental Hygiene Legal Service, that provides representation and advocacy on behalf of individuals who receive services for mental illness. So, yeah.
Okay. Will the next of kin encounter issues when making decisions if they don't have a POA and healthcare proxy? Yes, that's my quick answer. But Jamie, do you want to elaborate?
No, it's true. Even if you have a power of attorney, for example, banks will give you a hard time. They want, real specific language in that power of attorney. If it's not executed properly, there are always issues. Banks will say that you're missing language, or that the language isn't really on point for what you want to do, or if it's a specific type of bank account, or if you're trying to sell property, but the person did an initial next to, authority to manage real property issues. So simply having these documents is not enough. They really have to be executed the right way. Same thing with a healthcare proxy. Even if you have the document, there can be issues with it, and especially if you don't have one. Although there is, so for example, in New York, we have the Family Healthcare Decisions Act. So there's a hierarchy for certain individuals to make medical decisions on your behalf in the event you didn't sign a healthcare proxy and you didn't designate an agent. So for example, that hierarchy includes a court-appointed guardian, includes a spouse, includes an adult child, and you keep going through the family tree, and hopefully you have somebody who's available to step in and be your surrogate decision maker. The real issue occurs, and I've had this case before, where you don't have anybody who's available to serve as a surrogate decision maker. So you really have someone who's in a hospital and has no family, no one to step in under the law to act as a surrogate. I was actually just appointed in guardianship proceedings. I receive appointments as either a court evaluator or counsel to the individual who's alleged to be incapacitated. And we had a case where a woman was in the hospital. The hospital brought a guardianship because she didn't have any family to step in as a surrogate decision maker. They needed the court to appoint a guardian to step in and make decisions for her regarding end of life care.
Yeah, it's really upsetting. We did have a webinar a few months ago on solo aging. And I like to say we should all presume that we're solo agers, because a lot of it is things to do when you're young, right? It's how you want to live your life, no matter what, no matter if you have a spouse or children or loved ones around you. And one of the things is surround yourself, obviously, with people that bring you joy, and help you grow, and make sure that those folks are at different ages, because everybody has a different perspective. And so, but we're seeing a lot of that, a lot more solo aging. And let me just see as a question. Yes, it's definitely helpful to have folks with healthcare background or working with advocates, attorneys that do that. And or use, but right. Very good. They're having all sorts of discussions here in the chat. I love it. You're very welcome, Mira. Myra? Is it Myra, Jamie?
Myra.
Thank you, Myra. And thank you all for being here and adding to this conversation. I know there's much more. And oh, wait, let's see what Dana said. Thank you, Jamie and Nicole, for this great program. I had occasion to benefit from Jamie's expertise as a leader of the mental health law group at Meister Seelig Fein, and Jamie has presented similar information to our county bar association. I'm sure a lot of work went into preparing this, and I appreciate you both sharing your experience and making this available to the public and other professionals. So I ditto that, Jamie, for sharing that with us, because not often is all of this information so easily available to all of us, not only professionals, but also caregivers that really need this information and resources. So I'm so glad that you're here. Jamie, thank you. And we'll see you next time. Care Answered will be taking a little break for summertime, but we'll be back. And please let us know of subjects that you want to hear about, because we want to get it out to all of you. So thank you.
Thank you, Nicole. Thank you, everyone. Have a great day.
You too.